Hello everyone and welcome to another SDF COVID-19 webinar. I'm Dave Little, CEO of SDF, and today's webinar we will be discussing treatment and care for people with a stimulant problem under COVID-19 and beyond. We have extended today's webinar until 2:15, and if you're unable to join us to the very end, the entire webinar will be available on the SDF YouTube channel. This webinar was prompted by services seeing more people with stimulant problems presenting for help during the COVID-19 pandemic. Historically, Scotland has had a very large opioid and benzodiazepine problem and a very much smaller population of primary stimulant users who, it's fair to say, are not well catered for by existing service provision. Over the last few years, we've seen an increase in cocaine and crack use among the long-term opioid benzo population. The harms related to this have included an increase in overdose deaths where cocaine is implicated. And this increase in cocaine use has also been a significant factor in the HIV outbreak in Glasgow and the surrounding area. This webinar is an opportunity to revisit issues regarding the treatment of stimulant users, both primary stimulant users and those who use alongside opioids and other depressants. We have three speakers joining us today, and we're pleased to say we've got an international audience, international group of speakers today. Firstly, Tracy Klusker, Manager of Midlothian Substance Misuse Service in Dalkeith. Peter Blanken, who is Senior Researcher at the Parnassia Addiction Research Centre in the Netherlands. And finally, we will hear from Professor Adam Winstock, Consultant Psychiatrist and Addiction Medicine Specialist based in London. We'll hear from each speaker in turn, and then we will have a question and answer session at the end. Attendees can submit questions throughout the webinar. The questions tab appears on the control panel, which should be on the right-hand side of your screen. My colleague Austin Smith will join us for the discussion session at the end of the presentations, where he will summarize the questions being asked by the webinar attendees, and I will put questions to the panel. I'd now like to go to our first speaker and over to Tracy. Thanks very much, Tracy.
Thank you, Dave, and thank you for asking me to come on and speak today. My presentation probably asks more questions than it does answers. We're seeing a huge rise, certainly in the local area that I'm working in within Midlothian, and people using stimulants, specifically cocaine and crack cocaine. And we're seeing the huge devastation it's causing to the person themselves, the families, and the community that we're working in. So I thought for my webinar today, rather than me trying to describe the impact that the use of cocaine and stimulants can have on a person, their family, I would interview someone with lived experience of this, so they can give their own personal account to start off with of their personal journey using stimulants. And so I'll hand you over to my interview with John. Can you tell me how you first got into using cocaine?
I got into using cocaine because I thought I could use drugs. I knew I couldn't use alcohol. I was never able to use alcohol, but throughout my life, my adult life, I always used weed to manage my mental health and to manage my dependence on alcohol, and always used weed to manage my distress, really, and difficulties, I think. And then when I'd finished my academic kind of acquisition of degrees and stuff, my life wasn't sort of professionally fulfilled, and I was looking for excitement, I think, and managed through a friend of a friend in a club to get kind of weak cocaine, and then I focused on getting better cocaine. Really.
How did you approach services, and what kind of help did you manage to get?
Well, after I determined from a friend who I knew had recovered from using drugs, I got in touch with a general practitioner. He signed me off my work for a cocaine addiction. He wrote it down on my letter to my job, which created terrible havoc for me later on. That I felt the general practitioner, especially some of them, kept asking me if my partner knew. They were really irate I mean, they were only human, but it was terribly judgmental. I was always going about my nose and support for my nose and sleeping pills and stuff like this. And then I went to third sector support and was asked, what kind of music I liked, and I don't think they really understood the kind of desperation I was in. I was going downhill really quickly. When I wasn't using cocaine, I was hitting a kind of depression, and the only way to get out of the depression was to get more cocaine and building up this relationship with dealers. And through the process, I eventually went back to work, and there'd been an investigation into my practice because I was signed off for cocaine addiction. I hadn't actually done anything wrong apart from skip a few days and stuff like that, but I was under enormous scrutiny. I wasn't allowed to go back to my original place of work. I was supported through fellowship services, and I can't remember how, but I was given support in one-to-one counselling through 2000, which was really helpful. A one-to-one counselling support, and but I could not stop. And I used to go high on cocaine for counselling, and she used to say to me, if you get in your car, I have to call the police. I'm duty bound to call the police. So I would wait outside until she left her work. I would go down, take cocaine in the toilet at Waverley Station, go back up and take my car and go home. I just couldn't stop using it. And every day I would swear to on my son's life. I'd swear on my mother's life. I would throw cocaine over a gram of cocaine over the back fence. But in the next day I'd be crawling about looking for it. So I promised myself I would stop using cocaine when I was high on cocaine, but I couldn't stop using it with the come down. So it was this huge rush of kind of dopamine, and then this crushing feeling of defeat.
What support worked for you, John, to help you finally stop using cocaine?
Well, I was going to see one-to-one counsellor, and I was always using before going to see my counsellor, and she became quite frustrated and referred me to the NHS treatment centre in Edinburgh. And when I was homeless and injecting cocaine, they contacted me to say that they had managed to create a place for me despite my always been having used at assessments, and then they provided a place.
I think I'm cutting slightly too early for John, but it's just to say that John's now 5 years substance free after gaining a place at residential rehab in Edinburgh called LEAP. So it was a 12-step programme and intensive rehabilitation that worked for him. But if you listen to John's story, I prescribed for an NHS specialist service. What we're actually seeing is probably about 80% of our opiate users are now using either cocaine, but especially crack cocaine, and the complexities that we're seeing alongside this. And whilst we're doing, really good quality work in terms of managing opiate addiction, sometimes it feels like there's a gap there in terms of crack use, and this seems to be the drug of choice just now within the area that we're working in. And we're also seeing a rise in young people presenting as early as late teens that are using cocaine, but not in a recreational way. They're using it alongside downers and depressants, and we've seen an increase in more drug-induced psychosis within the area as a result of the rise in stimulant use. And we're also, in terms of the female population that we work with, the use of crack cocaine seems to increase their vulnerability and how they're funding that drug use. So certainly from a specialist service point of view, we've got real challenges, but I'm now going to hand over to our peer support coordinator in Midlothian, who can talk about that from a peer support coordination point of view, what he's seeing locally and what he feels the gaps are in NHS services.
So my name's Malcolm Paul. I'm the peer support coordinator in Midlothian. My background is I'm in recovery from alcohol and drugs myself. So I've got a personal knowledge, but I've also got a working knowledge for the people that I've supported over the last 5 years. Personally, I feel that stimulant use over the last 10 years has increased dramatically. Cocaine use back years ago, I think it was, people were dabbling, and especially in the circle that I was in. But there was more generic drugs like heroin and ecstasy, and people were dabbling in most things, you know. But I feel that in the last 10 years, like I say, the place has been flooded with cocaine. Younger people are, I feel, using a lot more stimulants on top of other substances. So there's an extreme polydrug use in the younger people, using street Valium, Xanax, any medication, to be honest, that they can get their hands on, and smoking copious amounts of cannabis green, which is a lot stronger as well. And I found that more 18 to 19-year-olds, and I was really surprised that they've actually been washing up their own cocaine into crack, you know, which I found astounding, because it was usually the older drug user who was doing that. And do you know what I mean? But these are young lads and girls as well, who have been using substances for 2-3 years and are now doing this kind of thing. The older generation, I feel, in Midlothian is who are using heroin are using a lot more crack cocaine as well. I don't know if that was because the heroin was that bad and they started substituting for crack cocaine, and then more heroin's come back in, so they've just been burning the candle at both ends with both substances, you know. And I'm guessing that they'll be using all the downers, the Valium and the Xanax and all that kind of thing as well. But the difficulty is that services, I don't feel, are set up for stimulant users. If you're using heroin, or you can present at the local substance misuse service and get started on methadone prescription or buprenorphine and things like that. There's nothing really for stimulant users. People who are using stimulants, like I say, are polydrug users, so they're using maybe Valium or methadone to come down, or heroin to come down, and then they're presenting, and that's what's getting dealt with. So they're not looking at the stimulant, and people, because it's socially acceptable, people don't think they've got a problem with stimulants. Do you know what I mean? Which I feel it's a definite, but it's, for me, I don't know what medication that you would prescribe someone on stimulants. You know, I feel that a bit of psychosocial work around why people are using stimulants on top of a medication. I think being able to speak to drug users and finding out what works for them and what would be beneficial is a way forward, you know, because there's a lot of help, a lot more help for opiate users.
That's great. Thanks very much, Tracy, and also to John and Malky for their contributions. That was a really useful scene setting for the Scottish context. We'll now move on to our second speaker, Peter, who's speaking from Rotterdam today. Thanks, Peter.
Yeah, good afternoon, and thank you for inviting me to speak. This is my first webinar, and it's for me, it's a new experience to do a presentation just in front of a computer and not in front of an audience. So I'll do my best. Well, as you can see, my talk will be about possible medications for the treatment of stimulant use disorder, and especially I will focus on sustained release dexamphetamine. And can I have the next slide, please? Because I will tell you a little bit about myself. I started doing research. I'm a researcher. I'm I'm not a professional who's in treatment, working in treatment agencies. I'm a researcher, and I started at the end of the 1980s in Rotterdam doing research, quantitative research in what I called at that time the natural habitat of users of heroin and cocaine, crack cocaine. So that meant at dealing addresses, at open drug scenes, at people's houses, but not related to treatment or the judicial system. And perhaps some of you recognize my fellow researchers. On the right is Nico Adriaans. He was a drug user and the founder of the Rotterdam Junkie Union. Next to him is Jean-Paul Grunt, also a well-known researcher. And next to me, because I'm on the left, is Cas Barendrecht. In this presentation, I will first say a little bit about good medical practice, then move on to the study that we did, the CATCH study. I will focus on sustained release dexamphetamine, and then I have some conclusions. Can I have the next slide, please? Because I think what is important to mention and to make clear, there can be many reasons or many goals for treatment. One, of course, is in case of crisis interventions. Most treatments are aimed at cure, that is to initiate abstinence and to prevent relapses. But my talk and the study I will be talking about is primarily aimed at care. That is caring for people who continue using drugs in spite of other treatment possibilities. And the goal of that treatment is to reduce or stabilize their substance use and to reduce physical, psychological, and potential social harms. Can I have the next slide, please? And as far as cocaine is concerned, there have been many, many studies, well over 100, with more than 10,000 patients, to see whether anticonvulsants, antidepressants, antipsychotics, disulfiram, dopamine agonists, or psychostimulants are effective in treating those patients. And as you can see on the next slide, there was not much evidence for most of these medications, except for the psychostimulants, and especially for dexamphetamine. Dexamphetamine might be effective in reducing drug use, promoting abstinence among cocaine users. Can I have the next slide, please? And around 2010 in The Hague, we started our study. It was called the CATCH study, Cocaine Addiction Treatments to Improve and Control and Reduce Harm. And we studied 3 medications. One was modafinil, the other one was topiramate, and the final one was sustained release dexamphetamine. And that will be the rest of my presentation. Can I have the next slide? Because dexamphetamine is an agonist medication for cocaine and stimulant use disorder. We all know that agonist treatment is very effective for opioid dependence, for opioid addiction, in the form of methadone and supervised heroin-assisted treatment, and to some extent buprenorphine as well. And it is also very effective in treating nicotine dependence. And it has been shown that combined nicotine replacement therapy with transdermal nicotine replacement, as well as chewing gum, is very effective. And as a matter of fact, I know a researcher, and he is most of the year on combined nicotine replacement therapy. And as you can see next, oh, well, I would have shown, because behind the packages, there was myself, because I'm on nicotine replacement therapy, and sometimes of the year, especially when I'm on holiday, I resume back to smoking for the time being. The rationale of agonist pharmacotherapy, like for heroin, as well as for nicotine and for cocaine, is that there should be a replacement of uncontrolled and potentially harmful use by controlled, medical, supervised, and relatively safe use. And the goal of agonist pharmacotherapy is to stabilize patients, their biology, their addiction-related behavior, to motivate them for additional recovery-oriented interventions. And it's always very crucial to balance potential benefits versus potential harms. And like I said, dexamphetamine sustained release is a good candidate for cocaine dependence. Can I have the next slide, please? So we started a study, and we did a study among patients with cocaine dependence in heroin-assisted treatment. And it was partly because that was very convenient and easy, because those patients visited the treatment center 7 days a week, 2 or 3 times per day. And it was very important because that made the study quite successful in the sense that of the 73 patients, 92% of all the prescribed medications was actually taken by the patients, and it was either dexamphetamine sustained release 60 milligrams per day or placebo. In the vast majority of the patients, they were still taking their medication in the final 4 weeks of the study. Now, the primary outcome of our study was the days of cocaine abstinence during the 12-week study period. And as you can see on the left bars in this slide, the yellow bar is dexamphetamine, and dexamphetamine patients abstained from cocaine during 12 weeks, 84 days, for almost half of the time, 39 days. And it was only 23 days of cocaine abstinence in placebo-treated patients. And it was highly significant. And also all our other secondary outcomes, cocaine-related, were in favor of sustained release dexamphetamine. Now, what is also important to mention is that treatment with dexamphetamine, we had indications that it also improved patients' health, their physical health, their social functioning, and their mental health. There were somewhat more medical adverse events, as they are called, in patients that received dexamphetamine compared to patients that were on placebo. And they were mainly related to sleep disturbances, agitation, and physical arousal, which you can expect for a stimulant medication. And they were mostly mild and transient. It's important there were no serious adverse events. And dexamphetamine was also safe in terms of blood pressure, in terms of body weight. So there were no increases in blood pressure, no decreases in body weight. And there was only some increase in heart rate for patients receiving dexamphetamine. Now, meanwhile, on the other side of the planet, as you can see in the next slide, there were also studies aiming at cocaine users, patients with cocaine use disorder. On the top is a study conducted in the United States by Frances Levin and her research group, and it studied the effects of extended release mixed amphetamine salts compared with placebo among patients with cocaine use disorder and ADHD, attention deficit hyperactivity disorder. And 60 and 80 milligram dexamphetamine sustained release, extended release, was more effective in reducing cocaine use days, the days patients used cocaine, and it reduced the symptoms of ADHD in comparison with placebo. Another study in the middle of the slide was conducted in the Scandinavian countries among patients with amphetamine use disorder and also comorbid attention deficit hyperactivity disorder. And it was high doses of methylphenidate, and it was more effective in reducing amphetamine and other drug use and in reducing ADHD symptoms. And finally, there's a study that's going on in Australia. It's called the Lima study, and they are using lisdexamphetamine, and that's kind of a form of sustained release dexamphetamine at high doses. And the study is still going on. And I think what is quite important to mention is that lisdexamphetamine is marketed in the United States and Canada, I believe, as Vivans, and at least in the Netherlands as Elvans. So it's a registered medication for the treatment of ADHD, and there are indications that it might also be effective for treating patients with cocaine use disorder as well as methamphetamine use disorder. So that might be an option for off-label prescription of Vivans, Elvans to patients with stimulant use disorder. Can I have the next slide, please? So my conclusion is, and I'll focus only that dexamphetamine in sustained release formulation, and I think that's very important. It's not the immediate release, but sustained release formulations of dexamphetamine is safe and it is effective agonist medication in the treatment of cocaine dependence, at least in the study that we did. We are planning all kind of follow-up studies in the future. And I think it's important to stress that when you prescribe stimulant medication, it's always a matter of balancing the effectiveness of the medication and the benefits, but also weigh the possible harms and the harmfulness of the intervention. But you should also take in account that when you don't have an intervention, it will also have can have very negative consequences for users of stimulants. So it's always balancing effectiveness, benefits, harms, and the consequences of unsuccessful or no intervention. Finally, I have one more thing to say, because I've been talking about agonist medication, so kind of stimulant drugs for stimulant use disorder. But there are also indications nowadays, and it's really preliminary, but that some psychedelics like ketamine may be effective in treating cocaine dependence. I think that's it for the moment. I would like to thank, as you can see in the next slide, all the participants of our study, the treatment staff, and some of my colleagues. Thank you very much.
Peter, thank you so much. That was a really great coverage of the evidence base around treatment, and I'm amazed that you did your 13 slides in the 10 minutes. So thanks so much for that. Our third speaker is Adam Winstock. Over to you, Adam. Thanks.
Hi, good afternoon, guys. Thank you so much for spending your Friday afternoon with this webinar. And I've been given a relatively easy task because of the great work Peter's done of trying to comment a little bit about what the barriers are translating some of that kind of clinical research into practice. And if we can have the next slide, please. So I think, as Tracy already pointed out, because there isn't as much money available and there's less access to drugs, we're going to have people coming in seeking treatment perhaps for the first time. And for opiates, of course, that's wonderful. People can come in, we can offer them methadone, but there isn't a cocodone. And the absence of that sort of pharmacological lollipop that we can give people and help keep people in treatment, I think, is one of the real issues that prevents us from doing a better job. So it's clear that Peter's outlined the fact that there probably is some evidence base out there that would allow us to prescribe in a substitute fashion some sort of long-acting stimulant. The first thing I'd think about is that long-acting stimulants that have a slow onset of action will, of course, not replace the euphoria that people who use crack are interested in. And I guess in the same way that methadone doesn't offer that for heroin, it's trying to balance the efficacy of something in replacing a high as opposed to replacing the discomfort of withdrawal. And that's certainly what a long-acting oral stimulant can do. But if you compare the evidence for substitution treatment for stimulants compared to the thousands of papers for methadone and buprenorphine, it doesn't come close. And I think that's one of the first barriers of us translating relatively limited evidence for substitution treatment into clinical practice. The other thing is, and Peter's already said this, is that one of the first guiding principles of medicine is first do no harm. And I can't agree with Peter more that we also have to recognize that by not doing anything, we are closing ourselves off to potentially therapeutic interventions, and that not treating people is leaving people at risk. I think there's also issues of stigma and racism here. So I think crack cocaine use is stigmatized by many other populations who use drugs. And I also think in some countries, it's seen as a problem for particular ethnic minority groups. And I think that the driver for developing treatments is probably greater, unfortunately, where a problem is perceived as something that's affecting white people or middle-class people, and there's perhaps less concern and understanding of the impact a drug like cocaine and crack may have on every population. One of the other reasons that I think doctors get uncomfortable about prescribing stimulants is that they get terrified about their prescription being diverted or being injected or being misused. And we have that all the time with methadone. And we know that daily supervised dispensing is a huge barrier to engaging and keeping people in treatment. And initially, one of the challenges when people were prescribed dexamphetamine was being able to know whether or not people were using on top, because street amphetamine, or would be a dipstick urine in exactly the same way as dexamphetamine would. You can differentiate them by the different isomers that amphetamine has made up of. But of course, if you're someone who's using cocaine, that's not a problem. You would be able to see someone's cocaine positive urines diminish and amphetamine positive urines hopefully being present. So I think fears of diversion are reasonable, but they can be managed by, I think, education, supervised dispensing, at least initially, and hopefully for patients understanding the benefits. Well, I think one of the other barriers is that not all groups are going to benefit from substitute prescribing in the way that most people who use heroin will benefit to some degree from methadone. And that's to do with your comorbidity. So about 30% of adult stimulant users are thought to have a dependence of ADHD. That's the thing that's placed them at risk of using stimulants in the first place, and very often is the thing that's maintaining their use. In order to diagnose ADHD, you need to take a childhood history. There are some screening forms, such as the Connors, that you would maybe get a parent or school teacher to complete. But typically, people who have got ADHD get a paradoxical response to illicit stimulants. So if I see someone who's a heavy cocaine user and I go, what do you like when you do coke? And they go, actually, I just feel quite normal and I can settle and focus and do things. That's a kind of paradoxical response you might expect to see in someone who has adult ADHD, as opposed to someone who doesn't, who says they do a line of coke and they start talking nonsense, running around and they can't focus. So there are clues that you can get from taking a history. But I think if we can start focusing our treatment on those groups where we know comorbidity is a risk for use and for relapse if untreated, then I think you might get psychiatrists feeling more comfortable that they're treating the comorbidity as opposed to the addiction. And I think the other reason we don't pay as much attention to getting a pharmacotherapy out there is that stimulants simply don't kill people in the same numbers and in the same predictable way as opiates do. You know, there's a dose of methadone and heroin that everyone watching this I could give you and you would die. With stimulants, there'd probably just be a different dose where you become more and more paranoid and eventually really psychotic and uncomfortable. But death would be a much more unlikely outcome. Of course, as we're getting better purity cocaine, which is better value for money and is more available, we are seeing escalating deaths because people are basically getting higher plasma levels and they're probably using more. So I think if we want to start challenging the way that treatment services engage and treat people with stimulant disorders, I think we want to focus on those groups where we know there's good wins. And I think that's people with adult ADHD, particularly within the prison setting. So I work within the prison setting, and although it's a fairly diabolical setting for trying to do a health job, you do have a captive audience who you can assess really well, often without the influence of, you know, people using lots of crack and coke. And you can get a diagnosis of ADHD because you've got time to get their records, and you can see the improvement in their levels of agitation and certainly crime. And if you want to sell a new treatment to a regulatory body or to a council, being able to say that people who've got adult ADHD who you treat with amphetamines not only do better from a health perspective, but stay in treatment and commit less crime, that becomes a really attractive financial nudge. And unfortunately, I think it's the economics of drug treatment that ultimately are going to lead to changes, not the fact that it's civil society and we lead to improved outcomes. The other group I think are really important, and Tracy alluded to this, is the very high rates of concurrent cocaine or crack use with other depressant drugs, most commonly alcohol. And Peter's alluded to the fact that there are some treatment trials looking at the utility of antabuse, treating cocaine use within the context of alcohol, and I think that can be quite helpful. But obviously, particularly worryingly within Scotland, is people managing their come downs from coke with illicit high purity benzo. So people end up with a secondary dependence. And that just becomes another issue because lots of doctors are not going to start prescribing benzos to people who are using their benzodiazepine to manage their cocaine use. Next slide, please. So I guess what I didn't want you to walk away with was a sense of, so there's all this evidence, but practically there's not very much we can do. And I mean, I think there are things we can do in terms of the way we change our conversations, the way we raise awareness among people that we see, and also things that we can offer. So I think particularly at the times of COVID, we need to kind of use of social distancing and safer crack cocaine use. So encouraging people not to share pipes and, you know, not even sharing kind of baggies of drugs, and getting them to understand the different risks when people are using by different routes. So one of the things that has always struck me is if you ask people who are in treatment and use heroin and coke, whether they inject. Non-injectors will look at you like, no, 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 I don't inject, there isn't a problem. I smoke. And it's how do you raise awareness among, for instance, crack cocaine users that smoking crack ain't good for your lungs. You have to kind of dismantle that belief that because they're just not at risk of HIV and hepatitis C, that somehow the route of administration is safe. And it isn't. There's risks of crack lung, people can get hemoptysis, you can get abnormal heart rhythms. But how do you demonstrate that to someone? And so a few years ago, in the clinic I worked in London, we used a thing called a lung age spirometer. So this is a little bit of equipment that costs about 60 quid. And on the front of it, you plug in your age, your gender, and your height. And with those parameters, you should be able to predict what your lung function is. And when you get people to blow into that machine, it will tell you how old your lungs are. And I have seen people who've been using crack for 20 years, face just fall apart when the machine says their lungs are that of an 80-year-old. And they look at you and say, well, what does that mean? Now, it's important that you don't say that this means your lungs are functioning of an 80-year-old and you're going to die. You use it as a way of demonstrating impaired respiratory function with crack cocaine use and the benefits of reducing smoking and tobacco, improving lung function. And for some people, that becomes kind of a wake-up call, why they're always short of breath, why they're always getting a respiratory infection. And again, within COVID times, we have a group who may be particularly susceptible. I think if you want to challenge the treatment paradigms your prescribing doctors are interested in doing, then I think focusing on treating comorbidity, not addiction, is the way to go. So adult ADHD and depression, which is diagnosed after people have gone through a period of abstinence, because virtually every single person who's dependent on a stimulant will appear depressed for at least 2 or 3 weeks after they stop. Which then links me into, is there anything we can do to help people manage withdrawal? Very often people are malnourished. They don't have enough monoamine precursors to make all those happy chemicals. So addressing malnutrition and improving diet among people who use stimulants, I think, is also a really useful thing to do. I think Peter's idea of long-acting stimulants that can be given once a day, that can possibly be used as a harm reduction stepping stone from injecting or smoking to eventual cessation, I think is a really good idea. Contingency management simply means giving people a non-drug reward for complying with treatment. Now, that doesn't have to be monetary. That could be a free ticket to the cinema if people give a cocaine negative urine, for example. The 3 other things I just want to finish off on are that there are some novel approaches out there. So obviously the mainstay of relapse prevention is going to be CBT and motivational interviewing. There is some interesting work going on at the moment looking at N-acetylcysteine, which is a sulfur-containing amino acid that is thought to disrupt glutamate transmission, and which in some trials for abstinent cannabis and cocaine users does seem to reduce craving and reduce outcome. It's remarkably well tolerated, got virtually no side effects. You can pick it up on Amazon. Doses are 2,000 to 4,000 milligrams a day. But if you feel that you want to prescribe something to someone, anyway, look at the evidence base and see what you think. The idea of ketamine being used to disrupt the memories associating stimulant drugs with pleasure is a really interesting area of work. And there's some good work coming out looking at how that might work for alcohol dependence. And my guess it will have utility for other drugs of dependence, as is, I expect, psychedelics that might help people suddenly understand either pre-existing trauma or the futility of ever trying to chase that first high. And so I think within 5 or 10 years, we will be seeing more research looking at how psychedelics might be of use among this group. The final thing is vaccines. And so the American government particularly have been trying to find a vaccine for cocaine use for the last 20 years. It's gone through phase 1 and 2 trials. Not surprisingly, one of the limiting effects is just how quickly the vaccine can work, basically stimulating antibodies to mop up all the cocaine before it hits your brain. But this is something I think governments will continue to look at. And my problem is the coercive utility of something like a vaccination, or, for example, particular health groups or universities saying before we're going to accept your child, they have to be vaccinated against coke. Using a treatment that abrogates someone of individual choices and encourages them to make their own personal behavior change, I'm not a huge fan of. If we can just go to the last slide. This has got nothing to do with crack cocaine. I'm just going to say the current special edition on COVID-19 is underway, and we're almost at 75,000 people. So if anybody listening hasn't done it or wants to put it out through social media, I would say thank you. I'm done.
That's great. Thanks, Adam. We'll give you that plug at the end. If we can all the speakers can come back on now, including yourself, Adam, and others. We've now got the question and answer session. But that was terrific contributions from all of you, and I think quite a few of us will want to watch that back again to take it all in, because there's so much information there that would be helpful to us going forward. I'm joined now by my colleague Austin Smith, who's been looking at all the questions, and he's had the hard task of sifting through those. So no pressure, Austin, but do you want to kick off with the first question or comment from those watching? I should say there's about 180 people watching, so hopefully one or two of you have actually asked a question.
Yeah, and there's capacity for more if people are thinking of questions as answers are coming in. Yeah, I mean, it's been hard to kind of group these, but I suppose the first question I think is probably symptomatic of the change in people who are presenting for help at services, at treatment services. So there's a question around the management of people who present in chaos and about heavy stimulant use, and particularly around behaviours, including violence or challenging behaviour, and also the challenging behaviour or the violent behaviour of dealers. So in terms of behaviour within a service or in a service setting, but also in terms of wider engagement, is there advice about managing that in the way it contrasts perhaps with people who are really principally using opiates and benzodiazepines?
Adam, do you want to take that first?
So certainly people who come in intoxicated on longer acting stimulants, particularly crystal meth, I mean, can be incredibly violent and aggressive, and that fear and violence is normally driven by persecutory delusions and auditory hallucinations. And I mean, the group they pose most challenge for are actually the ambulance staff and the police, because the normal ways that you would manage highly aroused people is by putting them in a position where you can inflict pain, and that pain stops people becoming aggressive. People high on stimulants have got the most insane threshold. They've got really quick reflexes, and they are really strong. So I think for service providers, the most important thing is the most important person in that room is yourself and other staff and other patients. And it's never placing yourself in a position where you may be placed at risk because of someone who is aggressive and violent. And my first port of call would always be protect yourself and others in the room. In terms of providing reassurance and stressing that you are not there as a threat, you are there to help, and keeping on message, that can be really important for someone who may be responding to 101 thoughts in their head. In terms of the clinical risk that group might be at, people who very often are psychotic and aggressive may also have severely elevated pulse, blood pressure, heart rate, their temperature can go up, they can be at risk of things like rhabdomyolysis. So in fact, recognizing there may be an acute medical risk here as well is also important, and therefore that's about bringing in the ambulance. But I've probably been more frightened with people high on crystal meth than I ever have with any other group because of their impulsivity and unpredictability. It's much less with coke because you don't have the same level of insomnia and where people have been up for 3 or 4 days, and that's often the thing that clicks you over. But I would implore you keep yourself and your staff safe before anyone else. It can be difficult to rationalize, and you keep yourself safe by distance, doors, glass, or anything else.
Thanks, Adam. Tracy, do you want to add from your experience in Midlothian?
We haven't actually seen an increase in any violent behaviours towards staff at all with this population, which is actually becoming the majority of our patients. And we have honest dialogue about the use of crack alongside their opiate replacement. The majority are on opiate replacement therapy. We have had to treat some people for psychotic symptoms whilst they continue to use crack because they don't feel able to stop. And they're seeking that euphoric feeling, and they can't get it from low quality heroin. So it's really very person centred, but we certainly don't have a population of people presenting who are aggressive towards our services, and I'm sure Malky would agree with that as well. I think there is more, what you do see is a difference in terms of what the clients are reporting to you, in terms of women being involved in more sex work, and there's all these other risks that there seems to be within the community, and along the lines of drug dealing and things. I think it's a different landscape, and there may be more violence involved from that perspective, certainly when people report back. But from a service point of view, no one's presenting more violent, as actually much more vulnerable.
Yeah, thanks. Peter, from a researcher point of view, have you anything to add to that?
No, like you say, I'm a researcher, and it sounds a bit silly, but I don't have experience in day-to-day treatment contact with people using stimulants.
Okay, thanks. Austin.
And then there's a question about linking treatment services that are strictly looking at treatment and detoxification with wider kind of community services, community-based services, mainstream services, and with support, including 12-step fellowship. And how is that developed? Is that different from the way things have been done traditionally with opiate and benzodiazepine users? And could we do that better, or is there examples of good practice?
Tracy, I guess that's a bit challenging from your point of view, because it's mostly combined use rather than primary stimulant users, which I guess is the question is aimed at.
We do actually have, and I certainly have had a small population who I have saw, mainly the roots came through the mental health team. They've presented when they're on sort of come down from cocaine and been very suicidal and unable to stop. It's a small population, but I have seen them, and they've mainly been linked in by, say, Malky, a peer support coordinator, or another from sort of the mental health team. And we have managed to get those referrals to LEAP actually, and we do have small numbers who, like John, whom I interviewed, who do follow 12 steps. You know, within our treatment centre in Dalkeith pre-COVID, we ran a Cocaine Anonymous meeting from our service, so we try and link people in to 12-step fellowships if that may help, or even sometimes to give people a bit of hope, and that also helps link them back into LEAP if you've got that lived experience. So we do use quite a lot of that with all our population, but we do actually have an in-service run. We have a fellowship, Cocaine Anonymous, who come into our service to provide that.
Thanks. Adam.
I mean, I think the biggest barrier might be that within services, once we see someone's using less heroin and they're on a decent dose of methadone, it's like, well, they're carrying on to use crack, but like we've ticked the medicine box. So, you know, they're probably using a bit less. It's almost that we don't use the fact we've engaged people in treatment with one medication lollipop to then work with them and almost identify crack cocaine as being as big a problem as their heroin use. So that's probably something within treatment services about upping our expectations. And that's why I think it's useful to have new toys to play with, new ways of assessing a client, new things to offer, that also for clients feels different. So when we did the spirometry thing, like these are patients who've been coming us to 10 years and said, no one's told me my lungs were screwed. It's like, they are, and it's like, oh shit. Or paying attention to that they're scrawny and malnourished and going, you know, do you want Pabrinex? No, it's like, we need to start offering things that make them think we have something of service when we can't prescribe methadone.
But why haven't we done that so far, Adam?
Well, I don't know, probably slashing budgets of 35% might have something to do with it. The government never really kind of paying much attention to the fact that more and more people are dying in the UK, and services probably scrambling to do the very best they can with sod all resources. I don't know, governments don't seem to give a shit, don't quite know what else you've got to demonstrate other than record rates of deaths in Europe. Maybe when we leave Brexit, it won't matter because we'll just have the highest rate of deaths in the UK on our own. poorly informed drug policy that simply doesn't get that what they're doing at the moment doesn't work.
But if you put it back to a service level, even with the limitations of resources, because you're talking about, I suppose, seeing people more holistically.
I think it's having someone to championing doing something differently. So when I introduced the idea of addressing malnutrition and lung age spirometry, the team went, yeah, lovely, we just hadn't thought about that. And they're really cheap things to do. Patients find it engaging. And what was lovely is we'd have patients leave the waiting room and they'd go outside and say, I've got bloody lungs of an 8-year-old. There'd be someone going, I can run a bloody marathon. And I'll say, why don't you get your ass in here? So you've got people in treatment talking to each other about how screwed their lungs were. And I'm thinking, that's good news. You're now aware of a whole bunch of harm that you dismissed because you didn't inject drugs. So biological measures that demonstrate harm are useful, and focusing on things that they're not always asked about, like diet and nutrition. It gets them thinking there's something else you can do. And they're cheap. It's altering your questions, that's all.
Yeah, that's useful. Peter, if I can bring you in more around your presentation, and why do you think it is that the research findings as they are have not been delivered in practice, and maybe specifically whether they have in the Netherlands, whether they have had more influence on treatment provision there, maybe in other European countries?
Well, I think that is because before a medication can be prescribed to patients with a stimulant use disorder, the medication has to be approved. In the United States, it's the FDA. In Europe, it's the European Medicines Agency, EMA. And we tried, or we had contact with the Dutch part of the EMA, CBG, and the trial that we did was not enough to have sustained release dexamphetamine registered as a medicinal product. So that's why we are planning to do follow-up studies and see whether we can have a larger, broader evidence base and try to go for a registration as a medicinal product again. So at the moment,
I was going to say,
go.
Yeah, come in, Adam.
I was just going to say, that's the value of focusing on treating the probably 20% of adult stimulant dependent users who've got ADHD, because Ritalin and lisdexamfetamine have already got licenses for treating ADHD. And so I'm not treating your stimulant dependence, I'm treating your ADHD. The fact it's also offering a substitute treatment is neither here nor there, because some of the evidence suggests that the reason that people on substitute treatment with ADHD meds do better is not because so much it's reducing their craving for their stimulants, it's because you're managing their ADHD, and then there is no regulatory hurdle. You just have to have a doctor go, I've assessed you, I think I've got you on ADHD diagnosis, here's some meds. And you bypass those dodgy regulatory issues.
Yeah, and in fact,
what are you prescribing then, Adam?
So it would normally be kind of Concerta, so long-acting methylphenidate. Yeah. Just because that's what I would treat anyone with adult and ADHD with, and so you're just any other patient. It's just you haven't been using a gram of coke a day before you started.
That's why you're prescribing then in high dosages, or?
Yes, it's normally higher than you would normally go. So 60 to 80s would be your starting dose. But you're right. Some people who don't seem to be overstimulated when they're using grams of crack and coke actually respond a little bit differently to methylphenidate, and they do feel uncomfortably buzzy. And that's lovely, because then you get them to understand that it's not a case of more drug is better. It's about finding a dose that lets you function during the day, not get withdrawal, and lets you sleep at night without having to drink 8 cans of Tennants or have a couple of benzos. So it does allow them to bring some structure into their day. Yeah, they don't get high. Oh well, you're not outscoring every day, and you look better and you feel better, and people go, yeah.
I was going to say that I was aware, I don't know if you know that, Peter, but I was aware of in the Netherlands where they were routinely testing people attending drug and alcohol treatment services for ADHD. Do you know if that's still the case? And I suppose that's
Well, as far as I know, that it's not longer the case. There is a lot of debate going on and discussion proponents who say we should do that because there's a high comorbidity of substance use disorder and ADHD. And there are also many people working in the addictions treatment. They say, well, we don't have to screen it properly because I just know it, or I just feel it, or I can just see it.
The crystal ball diagnosis.
Yeah.
Yes. Adam, is that something you've ever considered?
So in prison it does happen, but it doesn't happen as routinely as it should. You know, do I routinely screen everyone I see who's crack dependent within the prisons? No. Should I? Yes. Why not? Because I'd normally probably look to my psychiatric colleagues and we would do that together. So we probably got 3 or 4. It wouldn't be difficult to do routinely, and doing it in prison is a far better place than doing it when someone's out in the community running around and not turning up to their appointments. If you get someone in prison for a month, they've come off their, illicit stimulants, and then you can start doing a baseline. So it would be a relatively easy thing to do, but trying to do anything easy within prison is unbelievably bloody hard. Because prison will worry it's just another drug to get diverted. And what I would say is, well, it means that person's not coming back to prison, isn't going to be buying drugs on the wing, and will have a happier, healthier life. So that comes back down to the first do no harm. By not doing anything, you are doing harm. And I think Peter summarized that beautifully. Doctors need to understand, by not doing anything, you are guilty by omission.
Tracy, do you want to add to that?
When we do have referral rates, and we do see people we would suspect have ADHD and in NHS loading, they can be assessed for that and treated within our service.
That's really good.
We don't routinely do it, yeah. Mm-hmm.
Austin, back to you. You're on mute.
Yeah, eventually. There's a few questions from people who are trying to support young people who are in about a whole pattern of polysubstance use, mainly around benzos and cannabis, but also using stimulants and ecstasy and alcohol. And asking the 2 questions you would expect people in that situation to ask: how do I support these young people when they have there's concern about them, but they don't perceive themselves to be in harm or suffering harms? And also, is there any resources you'd recommend in supporting such young people?
Tracy, do you want to go first on that?
Well, what we're seeing now, and I think that's what Malky was alluding to, and certainly services, and we've had some discussion certainly locally, this is certainly what our homeless services are often in contact with us. Our young people service are seeing this. We have a specialist young people service for counselling. They're seeing more and more, and it's very harmful because of the use of downers that people are using as alcohol and benzos amongst teenagers, very young people. And I do think that, again, is part of this population we're seeing, that we see as a missed group, that I think we need to almost start looking at how we deliver services for that group as it stands. And just now we are doing it case by case, using all the specialist services, using the young people service, but we will see some of these young people or the mental health team will do it jointly. But that has been a real challenge for us, and there seems to be more of that increasing, especially since COVID, for young people as well. And we are currently looking at that locally, but what our response is going to be, because it's a new emerging population of young people using drugs harmfully, very dangerously.
Okay, thanks. Adam?
I mean, I always worry about the exploitation of that group and who's supplying the drugs, and what's effectively the coercive control either the dealer or whoever's running that network has over that group. And so that's a conversation I'd often start with, saying, where are you getting the drugs? Who's giving you the drugs? And then I guess it's about saying, where you have such a chaotic picture, I'm always interested, what's the effect that you're after? Like, what's that point of pleasure that you're interested in all of this chaos? And for some, of course, there is no point. It is It doesn't matter what it is. I simply don't want to be where I am when I'm sober. And that then allows you to start having a conversation about all the other stuff that's probably gone on in someone's life that's led them to that position. But for me, the focus is about reducing the risk of dangerous polydrug use while accepting that there's probably a very good rationale in their head. The other way of broaching that subject is not about risk to yourself, but are there other people in your network who use drugs in a similar fashion who you're worried about? And why are you worried about them? And it allows them to talk about the same sort of risk and chaos they have, but at a distance. But you can see as people start telling the story about, oh, my young friend, you know, she ended up God knows where after doing a whole bunch of benzos from someone. We don't know what happened to her. It's like, that could be you. You know, so thinking about risk in the third party can be a way of people disclosing all the other stuff that's going on, because you know it ain't just drugs. You know, trauma, comorbid mental health problems. Yeah.
And is that not an argument for keeping that group out of specialist treatment services or trying to intervene earlier with that population?
Oh, listen, you can spot that population before they're born. You know, Karen McCluskey in Glasgow has done beautiful epidemiological work on the relationship between alcohol and violence. And in Denmark or in Scandinavia, that's what they do. You can spot high-risk children because they're born into high-risk families. And that's why social pedagogy in Scandinavia invest in the first 5 years of life. But we don't do that. We wait till kids have screwed up or in the criminal justice system and then spend vast amounts of money with zero return. So, yeah, you spot vulnerability at birth. You support vulnerable parents to love, nurture, care, and feed their child. So by the time the kid is 5, he's secure, fed, and loved. But the return for a government on doing that, that's 20 years away. But that's what you would do. It's too late. By the time you get a 14-year-old that Tracy's just described, you're going to throw everything for the next 10 years, and your return is going to be the best you're going to do is maybe they live and maybe they get a little bit better, but you've missed your window of opportunity. That's when you're young. Sorry, it's a bit depressing, but it's true.
No, but it's certainly something we've argued for long and hard, is in terms of earlier intervention and family support from pregnancy.
Yeah, absolutely.
Yeah, Austin.
I've forgotten what the other question was. Oh, the other question was about medication. So there's interest in any comment around the possibility of substitution, any more information about that. And also, is there anything that would have a blocking effect, or is there any sign of a development of a medication that would act to block the effect of stimulants?
That's the vaccine that you're talking about, is it, that Adam referred to already?
Yeah, so that's the idea, that it will, you know, metabolize cocaine before it hits to your brain. I mean, other drugs that will have a kind of a dulling effect would be things like antipsychotics. But, you know, I think even for people with stimulant psychosis, my preference is just to put them to sleep with lots of benzos, as opposed to sticking anything else in their head. There isn't an naltrexone for coke. And I mean, antabuse for people who use cocaine works on a slightly aversive principle, that actually when you use coke, you become too agitated. And I think for people with alcohol and cocaine use who have got a non-drug using supportive partner who can dispense daily, I think that's worth trying, for sure. But the likelihood is for most clinical services, if next month you said we wanted to start doing this, you would probably have to start treating them for ADHD, or you'd have to set up a trial to defend what you were doing, and that takes time.
And I suppose going back to your earlier point, Adam, in terms of the comorbidity, isn't that the challenge also of dual diagnosis and you know, mental health teams working with addiction services?
I'm so bored of the flipping term dual diagnosis. I have no idea what it means. It's just a way of saying it's not my responsibility, bugger off to someone else. And, you know, it's you know what, so the fundamental problem with dual diagnosis services is that the people that cause mental health service problems, the people who are smoking lots of weed and, you know, maybe drinking a bit too much, they're not the groups that addiction services are very good dealing with. And then, you know, the biggest problem for people in drug treatment services are concurrent severe depression, PTSD, and that's not really what acute psychiatric services are any good for. Like, we're not very good at what the other person wants, and we kind of forget that quite a lot of the things we could all do if we just went, this is part of our day-to-day job. Yeah, sorry,
Yeah, I was meaning that as a phrase, that in terms of services being joined together better rather than Tracy, do you want to come in there?
That's been an ongoing long conversation strategy for some time, hasn't it? But I do think if we're more joined up with our addiction services and mental health services, we're more joined up, and we would be aiming to do that locally. It's seeing people as people, and they've all got different coping strategies, be that, you know, self-harming, or and the majority of people who are in our service have trauma, you know, childhood trauma, and it's treating the underlying cause and having access to good mental health support and psychological support. And it is just seeing the person in which service, you know, the services should be working around that person, not the person working around the services. And I think we really need to move. And I think the separation of both can feel quite stigmatising as well. I think sometimes the people who are using cocaine, mental health services sometimes might find that, you know, will just stop, whereas it's having to pick away at the underlying reasons why people are using any of the substances that they're using, and seeing that from a sort of mental health perspective as opposed to just an addiction perspective.
It's also a timely referral pathway. If you've got someone in treatment and you say, look, I'll refer you to mental health, and you come back and say, yeah, there's a 4-month waiting, you know, it's like you've missed your boat. So the one thing COVID, I think, has really changed is services are being delivered much more quickly in a way that is much more engaging and appropriate for our client group. And it's like, yes, that's because we always blamed our chaotic client group. No, it's because they're chaotic, therefore our structured treatment services don't work very well. And what COVID's done is we've had to be flexible, and lo and behold, patients go, actually, that suits me better. So I'm hoping we all work away from COVID going, you need to offer a more flexible service because that's what our patients need, not what happens to suit, you know, the convenience of a 9 to 5 life so I can go home and have a cup of coffee.
Peter, do you want to add to any of that conversation? I don't want to leave you out of the, the debate.
No, I think with respect to comorbidity, I think because we had that in the Netherlands before also, for the mental health agency said, well, you should go to the drug treatment agencies and vice versa. But over the past few years, maybe the past decades, there's quite some change that many addiction treatment organizations, they also address mental health problems. I think that's a good improvement over the years.
And Peter, it does happen.
Yeah, and I think I'm not so sure about whether COVID-19 has resulted in many positive changes in drug treatment services in the Netherlands. I don't, again, like I say, I'm only a researcher, but I don't know about stories of drug treatment agencies being more open and responding to patients' or clients' needs. I have the impression.
Your baseline treatment was really good, though. It was probably much less restrictive than it was in parts of the UK. So the Netherlands started from a really good base of pragmatic harm reduction and, you know, a range of services. In the UK, particularly in Scotland, we're all obsessed with you come to the pharmacy every day and take your methadone. Like, and
for instance, but many treatment agencies, they started doing online treatment sessions, so they're no longer seeing their patients. And what I know, for instance, from the heroin-assisted treatment programs, where patients are offered the possibility, they were offered the possibility to come 3 times a day, 7 days per week. It has become really restricted nowadays, and it's also because most of the patients, they are smoking, inhaling, chasing their dragon, heroin, which is quite time consuming compared to injecting. So we plan to do, or we are preparing to do a small survey on that. What are the consequences of measures taken to prevent COVID-19 by the heroin-assisted treatment programs? And what are the consequences for the treatment as well as for their for the substance use, non-prescribed substance use by the patients, including alcohol? So that are some of the things that are happening in the Netherlands. Yeah.
Thanks, Peter. Okay, I think Austin has one final question.
Yeah, hopefully a hopeful question and something to end on that's positive would be, have you any advice for non-specialist frontline services and workers working with this group about practical supports you can give to people around, you know, basic problems people have, including sleeping and making sure that they're safe and warm, as it were, the kind of fundamentals in life, and what supports can people be offered around that?
Tracy, do you want to?
I suppose it's that wraparound support, and it's the harm reduction work as well, about trying to minimise harm, making sure people are aware of the risks, so that there's some informed choice, ensuring people have got access to benefits, housing. You know, if you've got support, peer support, whatever support, you know, they feel would be helpful to them. We try to work, we work very closely with all the partner agencies that we work with, so it's almost like shared care, so it's not a case of, you know, prescription should be the only thing, there should be that wraparound, and it's increasing your links with housing, or an advocate, ensuring people have got an advocate, you know, involved if they need someone to advocate on their behalf for some of their needs that they have. But as that holistic care and actually making people feel valued and that you are listening, you might not be able to prescribe something to stop the stimulant use, but helping people understand it and do what you can practically. Certainly just now, a lot of the work we're doing is around ensuring people have got welfare, access to benefits and food, and, you know, a lot of housing issues. So all these other things can help improve what you can do in terms of people's quality of life. You know, we use mindfulness, you know, we've supplied our service users with smartphones so that they can use apps and things as well around mindfulness, and Zoom meetings and other ways of getting support and being connected to others, and that does seem to have some impact.
Thanks. Adam.
Yeah, I mean, it's addressing the social determinants of health, and, you know, where people are sharing crack pipes or kind of doing, you know, homemade crack pipes, spend a fiver, get yourself a glass pipe, don't share with other people. And then I think it's, you know, looking at how other drugs they're using are just being there to manage their crack use. And if their crack use falls, they'll probably drink less, they'll use less benzos. And then I think for the other group who are particularly vulnerable, not forgetting things around contraception and safe sex. So for those people who are being exploited in sex working, yeah, I mean, just good family planning and contraception are things that we, you know, it's sometimes the most useful thing that we've offered. We'll never see them again, but they walk out with a bunch of condoms and they realise they can get pregnant. So it's simple things.
Thanks. And Peter, do you want to say anything or give a final comment?
I agree with Tracy and Adam, and I don't think I have much to add on it.
Okay, that's great. Thanks to all of you. That was a really interesting session, and certainly the whole issue of services for stimulant users is one that won't go away, and it's helpful to have this session to try and help us progress services in the Scottish context and hopefully more widely than that, because I think we've had quite a few folk from England on the call as well. Okay, and that's concluding it really now. We'll have to end, and just to say that's the end of the webinar, and it will be recorded, or is recorded, and we'll publish that on our YouTube channel as soon as possible. You also can view all our previous webinars there. We will be sending out an evaluation, and it would be excellent if you could complete that for us. Our next webinar will be held on next Friday, the 19th of June at 1 p.m. The focus of the webinar will be on the care of injection-related wounds in people who use drugs. A link to register for this webinar will be included in the evaluation email you'll receive So it'll be great if you can join us again next week. So finally, I'd just like to thank you all for attending, and a special thanks to today's speakers, Tracy, Peter and Adam, for what has been a very informative session. I hope you'll agree. Thanks again and goodbye.
Bye guys.